is going to be very imminent because we could see that there will be a great change in how the traditional services across the world is going to be provided, largely because of the availability now of all the new technology, the mindset of people, the introduction of AI into almost every walk of our normal day-to-day life. The demand for fertility services across the globe is very likely to continue to increase. This is partly due to the global decline in fertility rates. The global fertility rate in 2020 stood at about 2.3, which is just marginally above the replacement rate of 2.1, which allows a new generation to replace itself. This is down probably more than 2 times from the fertility rate of 4.7, which was actually recorded in the early 1960s. And at the moment, nearly 2/3 of the world population live in countries where the fertility rate is actually below the critical 2.1 threshold. Every year, approximately 20 million people will be faced with fertility problems, and only, I would say, about 1 to 2% of those will have access to fertility assistance or services across the globe. This is largely because traditionally over the years, and despite the fact that IVF in particular has been around for over 40 years, the traditional way of providing services has remained across the board, and this doesn't apply to any particular country, has remained unchanged in so many ways. The services that we provide in IVF clinics is still largely manual, analog, and prone to error, and probably difficult to scale, and inefficient, and also inconsistent in how we provide the services and the results that are differing between different places. Faced with all of this, I think the solution now is all the technology that is available around us, and also the mindset of the newer generations, the Generation Z, which are people born after 1995 or 1996. We have to really look into a more efficient way, more consistent way, maybe more affordable way of providing services, making use of all these great breakthroughs in the technology around us, and the attitude of people towards embracing those technologies in their day-to-day life, including the need for services, medical services, or fertility services in particular. If we are able to embrace those kind of technologies into our day-to-day practice, which I think is very likely to happen very soon. I'm not talking about 5 or 10 years down the line, possibly we're talking 2 to 3 years maximum, and we could see already evidence of that in the Western world, where a lot of the reliance on technology is creeping into how we traditionally sort of changing what we used to provide in IVF and in the clinics in general. Our presentation is aimed to share with you our vision for what we think is going to happen in the very near future. There is already evidence of many of this new technology creeping into the day-to-day services, particularly in the Western world, and I'm sure this will also creep into our services in our part of the world, in the Middle East and so on. We hope that this will improve the quality of the service, will allow for easier scalability, maybe better results, and probably being more affordable to a very large group of patients. We hope that by the introduction and the reliance on the technology that is around us now, we will be able to help more and more people. I hope you find the presentation informative, and thank you again for inviting us to speak into this conference, and we look forward maybe to meeting with some of you in the very near future, either in the UK or back in Egypt. Thank you.
Driven by declining fertility rates and shifts towards later parenthood. However, traditional clinics are unable to cope. There is a pressing need for innovation in fertility services, as IVF clinics worldwide grapple with scalability, inefficiencies, and staff shortages. In recent years, we have seen a trend of simply increasing the number of clinics. This strategy, driven from a business perspective, is outdated. Increasing the number of clinics does not equate to enhanced patient experiences or outcomes. If our clinics are under-resourced or our staff overstretched, it can compromise the quality of care that we provide. And this isn't merely a logistical problem, but a qualitative one. Gen Z are our next generation of patients. These young people are digital natives. They seek streamlined, technologically enhanced experiences that go beyond the traditional clinic visit. We are at a pivotal moment where we must change from a purely expansionist mindset to one of modernisation and efficiency. So what is the way forward? We believe that it is essential to look beyond the number of clinics and instead focus on leveraging technology, rethinking our processes, and ensuring we offer top-tier training and support for our professionals. Today, we will be discussing just this. Not merely the challenges, but the incredible opportunities that await us as we rethink the future of fertility treatments. Let's begin this journey towards a more integrated, efficient, and patient-focused future.
ARGC is renowned for its outstanding IVF success rates every year since 1995, achieving some of the highest figures in the world. This is despite the fact that at least 75% of our patients come to us after multiple failed attempts elsewhere. So what sets ARGC apart? We see each patient journey as a unique. Before treatment, we study each patient through a natural menstrual cycle, advising on health, diet, and microbiome enhancement. All ovarian stimulation cycles are monitored by daily blood tests and frequent ultrasound scans, which allows us to pick up the slightest hormonal changes which may impact on the choice and dosage of their medications. We think that this careful preparation, monitoring, and attention to detail accounts for 70% of our success. The other 30% occurs post-egg collection and embryo transfer, where we closely monitor patients during a crucial 2-week wait, adjusting medications based on blood tests to aid the implanting embryo. And our care continues even after a positive beta HCG, where we support a healthy pregnancy throughout the early stages. At ARGC, we are constantly looking for ways to improve the chances of success for our patients. Historically, we have initiated a number of techniques in the UK, which have since become accepted practice in other fertility clinics. We were the first in the UK to be granted a license to freeze and later thaw eggs. We were also the first clinic where a baby was conceived from the use of frozen eggs. We were the first clinic to offer genetic screening of embryos and the first to offer HLA tagging. And since 2002, we have pioneered the investigation of recurrent implantation failure of embryos and the immunology of implantation. While our approach's results speak for themselves, we recognise the intensity and demands it places on both our patients and our staff. That is why we're now looking towards the future and exploring how modern technology can enhance our processes, making the journey smoother for our patients. Historically, artificial intelligence and digital technologies have concentrated on embryology, including the analysis of sperm, eggs, and embryo quality. However, we believe that there is an expanding scope for application beyond the laboratory, with the potential for integrating into the wider realm of the fertility journey as a whole. This digital universe can change the fertility treatment landscape, improve patient care, and address the recruitment and retention staffing crisis facing fertility clinics worldwide.
Through a detailed analysis of the patient's journey in the fertility treatment process, it becomes evident how technology can be intricately integrated at every turn. This systematic integration not only amplifies the efficiency of each step, but also enhances the overall patient experience, ushering in a new era of patient-centered care. So let us take a look at what technologies are currently available in the global fertility space and apply them to each step of the patient journey. The average medium-sized fertility clinic performs around 1,250 initial patient consultations per year. Before commencing treatment, the average fertility patient explores 5 different clinics, and attends up to 3 initial consultations before finally choosing their preferred clinic. Each patient requires a minimum of 5 hours of repetitive clinical information provision from nurses, embryologists and doctors per treatment cycle. Now, we know that fertility clinics around the world are experiencing difficulties in recruiting and retraining staff. So in the MENA region alone, this may equate to around 625 hours of doctors' time wasted per year per clinic on patients who have had a consultation but do not come for treatment. It also requires over 1.2 million hours of clinical staff time giving repetitive information. The information discussed with patients during both an initial fertility consultation and whilst the patient is on treatment is largely repetitive with limited choice of different scenarios. Our solution, both to the global staffing situation and to improving patient care, is a state-of-the-art holographic voice avatar chatbot designed to mimic the look and sound of a fertility doctor. It allows virtual consultations that simulate the experience of patients being in the clinic in person, with fertility experts represented as avatars or holograms. This innovative approach grants patients the ability to seek medical advice and explore potential treatments from their own homes, eliminating geographical boundaries. Furthermore, these virtual services can be made available 24 hours a day, ensuring accessibility at all times. To foster greater access and inclusivity, these avatar-guided sessions can be designed to support multiple languages and be customized to meet the needs of diverse cultural contexts, providing resources that are attuned to a variety of backgrounds and belief systems.
Within the realm of pre-treatment preparation and protocol selection, there are multiple devices on the market that can perform at-home testing for LH and progesterone. A new one, IFM, can also test for urinary estrogen 3. It is an accurate and quantitative home test for tracking menstrual hormones, which outperforms older over-the-counter tests and could soon help doctors diagnose and adjust fertility treatments based on data women gather at home. At-home kits that utilize the iPhone's camera and AI technology can perform sperm analysis. HelloBiome is a microbiome testing platform that merges state-of-the-art next-generation sequencing with patent-pending AI-powered technology. And IMA, which is an at-home self-scanning platform, can be used for pre-treatment monitoring or even during ovarian tracking.
Ovarian stimulation, pivotal to the quality of eggs retrieved, must undergo transformative change. Traditionally, patients face daily clinic visits for hormone testing and extensive in-person sessions for medication guidance and consent. The future envisions a streamlined approach, harnessing data-driven personalised hormone protocols. By leveraging collaborations with at-home testing companies, future protocols will use capillary or saliva blood tests and self-scanning ultrasound technology with follicle recognition software that utilises automated imaging ultrasonography, accurate identification and measurement of ovarian follicles. The amalgamation of this point-of-care monitoring during the ovarian stimulation with advanced software algorithms allows for at-home artificial intelligence prescribing of follicle-stimulating medications. The testing of hormones in saliva is increasing in proficiency, and companies such as MIM Fertility are developing AI algorithms that can read ovarian ultrasounds.
This string will show you where exactly Folliskin found the follicles. We make sure that when the specific follicle is found, the system distinguishes and follows it through the video.
At ARGC, we have developed a prototype software ovarian stimulation algorithm that is able to independently prescribe medication throughout an IVF cycle.
In the realm of embryology, automation and AI have emerged as game changers, streamlining precision and amplifying post-procedural patient care. By leveraging AI, the intricate selection of eggs, sperm and embryos is undergoing transformative refinement. For egg selection, AI algorithms meticulously examine microscopic imagery, gauging egg quality through morphological attributes and spotlighting those ideal for successful IVF. In sperm selection, AI analyzes sperm samples, evaluating vital criteria such as motility, morphology, and concentration, ensuring the most viable sperm are chosen for procedures like ICSI. Furthermore, embryo selection stands as a testament to AI's pivotal role in labs, with systems analysing time-lapse imagery of embryonic development and harnessing data-driven algorithms to earmark embryos with best potential for implantation. This amalgamation of automation and AI not only fine-tunes laboratory operations, but has the potential to elevate patient outcomes in assisted reproductive procedures. As we journey forward, innovations like robotic IVF with sperm-injecting robots operated by PlayStation controllers and the pioneering use of microfluidics for enhanced sperm selection are setting the stage for a revolution in IVF. Cryopreservation, a key component of ART, addresses diverse needs, from preserving fertility for health or personal motives to storing surplus embryos post-IVF, ensuring they're available for prospective uses. In the MENA region, the demand for egg freezing has seen an exponential surge, driven by the implications of the COVID-19 pandemic and recent regulatory changes. Simultaneously, advancements in ART worldwide are mirroring this trend, enhancing freezing and storage techniques. New FDA-approved automated systems offer a streamlined approach to managing frozen eggs and embryos, complete with digital identification and meticulous tracking features.
Tomorrow's proprietary RFID technology ensures chain of identity for each sample at all times.
Monitoring post-embryo transfer and throughout the initial phases of pregnancy is paramount for achieving positive results. In this critical period, innovative tools come to the fore. Leveraging a sophisticated software medication algorithm, point-of-care blood tests and urine tests are analysed in real time. This system promptly adjusts the medication, ensuring that it aligns with the body's changing needs as it adapts to the implanting embryo. Furthermore, the advent of self-scanning capabilities, facilitated by a smartphone-integrated baby scanner app, offers expectant parents the unique opportunity to continuously monitor the progression and well-being of the growing fetus. This blend of technology not only streamlines the process, but also instills confidence and assurance during the formative stages of pregnancy. In conclusion, the evolving landscape of healthcare, especially within the fertility sector, demands a thoughtful and innovative approach. Simply increasing the number of clinics isn't the definitive answer. Our strategy for meeting these growing needs has to be more nuanced. As we traverse the digital age, relying solely on expanding clinical numbers is not the most effective or holistic solution. The entire fertility journey offers ample opportunities for technological integration, from the initial patient consultation with avatar-based interactions, to point-of-care ovarian stimulation and home-based scanning, to the laboratory, where automation and AI can handle routine tasks. This allows our medical professionals to zero in on specialised procedures, ensuring precision and expertise. However, it's essential to understand that this isn't about supplementing human interaction. Instead, it's about leveraging technology to augment it, creating a harmonious blend of digital tools and human touchpoints in the fertility journey. This integration ensures a heightened patient experience, better outcomes, and a synthesis of personalised care and cutting-edge technology. As we look to the future and cater to the unique needs of millennials and Generation Z, clinics that seamlessly embrace and integrate technology will not only set industry standards, but also resonate deeply with the tech-savvy generations.
Hello. I would like to thank the organizing committee and especially the board presidents for their kind invitation. I would like to transfer greetings from Professor Papanikolaou. Unfortunately, we cannot be present because of a parallel congress taking place in our department. Hopefully, we'll meet up in a future congress. My lecture title is Is diagnostic hysteroscopy an effective tool pre-IVF? So I report no conflict of interest. In order to answer question on whether hysteroscopy should be performed before IVF, we have to answer first the following questions. Shall we evaluate the cavity pre-IVF? What methods do you have for the evaluation? Comparison of different methods. What is the impact of hysteroscopy? And finally, to answer the question, is hysteroscopy necessary? What we already know is that the number of infertile couples is growing worldwide. Live birth rate in women undergoing IVF is about 29%. Even after pre-implantation, genetic screening pregnancy rates do not exceed 64%. Despite the high cost, the success rate of IVF remains a major challenge, with still many unexplained gaps. Uterine factors or molecular alterations may negatively impact the implantation of an embryo. So, we have some major categories of infertility, like ovulatory dysfunction and anovulation, tubal infertility, endometriosis, diminished ovarian reserve, uterine and cervical factors, male factors, and unexplained infertility. My topic will deal with these uterine and cervical factors. Let's start with a few words for office hysteroscopy. We all know that the success rate is high, almost 98%, many advantages, more valid than dilatation curettage, easy to use in an outpatient setting, useful element of various diagnostic approaches, preparing step for the probably next step in the operation procedure, and of course, the advantage of hysteroscopy, see and treat. We see pathology, we can treat it usually at the same time. Revolutionary technique, direct visual depiction of the endocervix and endometrial cavity. We have the advantage to do visually guided biopsies and immediate restoration treatment of lesions. And the most important thing about the training for our students is an easy learning curve. Clinical possibilities of office hysteroscopy, visual depiction of the endocervix and the endometrial cavity, combination with ultrasound, recognition of coexisting pathology, diagnosis of subtle lesions, and diagnosis of possible expansion of adenocarcinoma to the endocervix. Elmanzi, in 2011, investigated the endometrial pathology before assisted reproductive techniques. He found that the prevalence of one or more intrauterine abnormalities in asymptomatic women undergoing office hysteroscopy prior to IVF was up to 25%. 45% of women with recurrent implantation failure had an intrauterine pathology. What are the commonest findings? Endometrial polyps, submucous fibroids, septate uterus, and intrauterine adhesion. The common mechanism of this pathology has to do with distortion of the uterine cavity symmetry and obstruction of tubal passages. A retrospective study from our team in Thessaloniki, published in 2023, investigates the intrauterine pathology in oocyte donation cycles. What we found is that 1 out of 5 donor oocyte recipients may be diagnosed with intrauterine pathology, and apart from that, almost 40% of recurrent implantation failure donors could have abnormal hysteroscopic findings. Which methods do we have to evaluate the uterine cavity? Ultrasound, saline infusion sonography, hysterosalpingography, MRI, and of course, hysteroscopy. We all know that uterine cavity abnormalities are associated with adverse pregnancy outcome like miscarriage and preterm birth. Saline infusion sonohysterography detects polyps or leiomyomas with sensitivity 91% and specificity 84%, making saline infusion sonohysterography superior to hysterosalpingogram and transvaginal sonography. If we suspect congenital malformation, then 3D TVS or magnetic resonance is suggested, but there is no high-quality evidence to support the routine use of hysteroscopy as a diagnostic test for fertility etiology when we have normal TVS or saline infusion sonohysterography. Professor Gribizis from Thessaloniki in 2016 made a prospective comparison of TVS, saline infusion sonohysterography, and diagnostic hysteroscopy in the evaluation of intrauterine pathology. The results show that saline infusion sonohysterography was more accurate as a method compared with TVS, and diagnostic hysteroscopy appeared to be the best technique compared with the others. So compared with saline infusion sonohysterography and transvaginal sonography. One other study, with few cases though, tried to compare 3D transvaginal sonography in detective uterine cavity abnormalities in infertile patients compared with hysteroscopy. Diagnostic hysteroscopy performed successfully in all patients. 3D transvaginal sonography had 84.1 diagnostic accuracy in comparison with hysteroscopy, 68.2% sensitivity, 91.5% specificity, 79% positive predictive value, and 86% negative predictive value. So, is there a need for hysteroscopy? And if yes, when? Pre-IVF? Only in recurrent implantation failure cases, or in both cases? We all agree that diagnostic hysteroscopy prior IVF may reveal intrauterine pathology that may not be detected by routine transvaginal sonography. A prospective observational study in 2003 examined 55 patients with normal uterine cavity on hysterosalpingography before the initial IVF cycle. Those patients have 2 previous failed IVF attempts, and the results showed high incidence on pathologic findings in patients with recurrent implantation failure. And the suggestion was that evaluation of endometrial cavity by hysteroscopy is highly valuable. Another systematic review and meta-analysis from El-Tuki and his team in 2008 showed that outpatient hysteroscopy might be associated with improved IVF outcome when performed immediately before commencing an IVF cycle. Another review and meta-analysis from the same team at Guy's and St. Thomas's Hospital in 2014 have same findings in favor of hysteroscopy just before IVF cycle. Trophy trial, a multi-center randomized control trial from 2016. The population was actually women younger than 38 years, BMI less than 35. Women had failed 2 to 4 IVF or ET cycles, and all women had normal TVS of uterine cavity. In contrast with previous publication, this study showed that outpatient hysteroscopy before in vitro fertilization treatment in women with normal ultrasound of uterine cavity and a history of 2 to failed in vitro fertilization treatment cycle does not improve the live birth rate. Another meta-analysis from Saleh and his colleagues, including 5 RCTs with a total 2,636 patients, showed that the routine use of hysteroscopy in both women scheduled for either for first IVF or with recurrent IVF failure the evidence is insufficient to support hysteroscopy. We have recently published guidelines from the Unexplained Infertility Guideline Development Group, DESRE, published in 2023. In the patient, which diagnostic procedure should be performed to confirm a normal uterine structure, anatomy, uterine wall, or myometrium? The 3D ultrasound showed superior result compared with the 2D ultrasound. In the question, which additional diagnostic procedure should be performed to confirm an anatomically normal uterine cavity? Evidence was not able to show any benefit for routine hysteroscopy. So, the recommendations are ultrasound, preferably 3D, is recommended to exclude uterine anomalies in women with unexplained infertility. MRI is not recommended as a first line test to confirm a normal uterine structure and anatomy. And if ultrasound assessment of uterine cavity is normal, no further evaluation needed. Same group in ESRE made recommendation for patients with recurrent implantation failure, and we have the following recommendations. If 3D ultrasound has not been performed at fertility workup, it can be considered. Hysteroscopy can be considered, especially when there is a suspicion of uterine anomaly visualized on transvaginal ultrasound. Poor pregnancy rates. There are not enough prospective randomized trials to clearly demonstrate that surgical removal of all intrauterine abnormalities improve fertility or IVF outcomes. Published observational studies suggest a benefit from resection of endometrial polyps, which may improve the clinical pregnancy rates. As it is the most costly and invasive method, it should be reserved for further evaluation and treatment of abnormalities defined by less invasive methods such as hysteroscopiogram and sonography. Thank you very much.